I'm very honored to be here. My name is Longrois. I work in Paris, France. And I will attempt, following this beautiful presentation, to try to make a few proposals, and you will have a very important role on how one could put together those pieces of information to build up clinical algorithm that you could apply to an individual patient for managing all the components of anesthesia. So here are my conflicts of interest, and I think the most important one are not the financial ones, but I have an academic credo that probably the missing part of the present day literature in all domains is going from knowledge, evidence, guidelines, many articles, thousands of patients, to a decision making for an individual patient, and then management of uncertainty. Okay, so I think as a start, my credo is that there will be still uncertainty. No matter how many monitors you will put around a patient, you will still have uncertainty. So a given monitor, what will do on a background of what you're using already, will take away some of the uncertainty. But the question, does it work in all cases, should never come. Nothing can work in all cases. You decrease the level of uncertainty. So I will briefly go with you through a few items of pharmacology, which I think are the basis, because if the pharmacology is not well understood, I'm sorry to, if you're very familiar with that, I apologize in advance, then try to see what could be the elements on which we could build the algorithm, propose the algorithm, and a few take-home messages. So this is, you've seen the components, which are separate, but anesthesia is a pharmacologically induced and reversible alteration of consciousness, which is a very complex phenomenon. We don't know how to define that. And the first element is drugs. So the drugs, there's a divide between Europe and the United States because the TCI is not accepted and not FDA approved in the United States, but in Europe TCI is approved. So thinking or using TCI actually facilitates, because it is much easier, I'll give you a few examples, to think TCI than dose. Because if you want to titrate, it is much easier to think concentration at the effect side than the dose. Now, each time we take this issue of drugs into consideration, we need to look specifically at hypnotic opioid interactions. It is absolutely mandatory. And then you have something which is the perceived level of nociceptive stimulation. So if you have a local regional anesthesia, the whole system will shift. Okay? They're still valid, so local regional anesthesia and general anesthesia. If you block the arrival of nociceptive stimuli, the whole system will be changed. And then, of course, if you have an opioid-free cocktail, then you also will change the level of perceived nociceptive anesthesia. And then you will look at the endpoints. It's multimodal, so you cannot imagine 1 second that a very complex phenomenon such as general anesthesia will be adequately described with 1 or 2 parameters. I think you need several parameters. So they're clinical. I put MAP and heart rate in the clinical because they're part of the clinical. And then you have many infraclinical. So what actually brings us here together is the monitors which look at somehow the balance between sympathetic and parasympathetic nervous system, which allow us to look at the nociceptive, anti-nociceptive balance. They are all based on some estimation of this equilibrium. And then I put back here the pharmacology calibrated. So here, if I tell you I have a MAC, okay, it's an uncalibrated parameter. If I tell you this is a CE, it's effect site concentration, propofol, 4 microgram per ml, it's uncalibrated. If I know that Professor Sessler that I put to sleep lost verbal contact with me at propofol, estimated propofol site effect concentration of 3.5, that becomes an important value for me and Professor Sessler as a patient, because I calibrated his requirements upon loss of response to verbal command. Okay? And then the issue is, if we go on the right side of the panel, for each parameter, you need to know what the raw signal is. It's mandatory. You also need to integrate, of course, pharmacology. Then you need to know how artifacts are recognized, and then you need something for you to validate the numerical value. It is mandatory. You cannot rely only on the device to validate the numerical value. And then, well, the time to peak effect. That is something tricky. Because if you take MAP, if it's invasive, what is the time to peak effect of MAP? It's 10 to 15 seconds because it's averaged. But if you look at the raw signals, it's basically instantaneous. Heart rate is average on 10 to 15 seconds. And if it's non-invasive MAP, what is the time to peak effect? It is the interval between two measurements. So if you set 5 minutes, the time to peak effect is going to be 5 minutes. And if you set 2 minutes, the time to peak effect is going to be 2 minutes, okay? Similar for the BIS, similar for the NOL, etc. And then you need to look at the interactions among parameters and then the algorithm for titration. So basically, we have a three-dimensional possibility, MAP and heart rate. I put heart rate between brackets because of what Professor Sessler explained to you. So I still look at it, but it's between brackets after MAP. A numerical EEG, I don't put a number. I put numerical and EEG, okay? It's two complementary things. And then you have the nociceptive, anti-nociceptive balance, which is NOL in this case, and green means everything is fine. Well, I didn't put any numerical data on this, but now you need to see what the confounding could be. So hemodynamic can be confounded by many things. I won't tell you this. When you look at the numerical EEG and also at the NOL, you need to have a solid basis on pharmacology, and then you need to be aware, both in anticipation and in reaction, of what is going on in the aura. What are the clinical nociceptive stimuli? And if you put numerical values, it adds. Those are the widely accepted numerical values. Now you can debate on whether MAP is plus minus 20% or plus minus 10%. I would say 20 because 10 is within the noise. Okay? And then you have the NOL, which has been explained by Professor Sessler, 10 to 25. This is your target. And then you have the BIS or other numerical EEG, 45 to 60. It's helped. So it's not rocket science. It's not very solid, but clinically it helps. And then in some situations, in some patients, the three parameters will react concordantly to a clinical stimulus. So in this case, you need only one of them, okay? Because one can substitute for the two others. The problem is there are situations, and we can all show you the personal data. MAP doesn't move. The NOL goes up, and the BIS is low. And you have any type of different combination of discordant changes. We don't know what is the percentage of time in the published literature during which those three parameters are concordant or discordant, but believe me, they can be discordant. And you all know that they are. So let me go back a little bit to pharmacology. Professor Sessler told you about inter-individual variation. This is old data, 1988. The green circle would be the affected dose 50, and you would have the extremes. This patient here on the left would be very sensitive. This is plasma alfentanyl concentration, but you can repeat it with alfentanyl, with fentanyl, with whatsoever, remifentanil. And this is the probability of no response. And that patient is very resistant. Now, if you look at the number of patients, it's less than 50. And if you look at the PK/PD modeling in most of the data which are published, the time to peak effect were calculated as an average or a median based on less than 50 patients in each case. Okay? So this is the interpatient variability. Now, it's quite high. And if you increase the number of patients, it's going to be even larger. Now, the issue is, how does this apply to hypnotics? Professor Sessler told you that interpatient variability for hypnotics is low. We published this many years ago, only 21 patients. We gave them a fixed inhaled concentration of sevoflurane. And the question being asked was, what was the time to define endpoints of anesthesia? So look at loss of response to verbal contact, 75 seconds in median, but goes to 45 seconds to 105. This is a 1 to 2.3 increase. Now if you look BIS 40, it goes 3 minutes on average, sorry, median, but it goes from 90 to 840 seconds, which is 1 to 9.3. And if you actually replicate what we did, this in green is the inspired concentration of sevoflurane. This is the end tidal. The black points are, so this is predicted. The black points are measured. And this is the predicted brain concentration of sevoflurane. And look at this patient. So if you look here, love or response to verbal command, look at the predicted concentration of sevoflurane for that patient who lost very, very low. So my analysis of the literature is that the way you look at interpatient variability gives you either what Professor Sessler told you, not much of an interpatient variability, or this kind of difference. So the bottom line is that interpatient variability is very large, both for hypnotics and for the opioids. So the pharmacological statistical approach, even with TCI, underestimates interpatient variability. So you need monitors to look at it. Now, this issue now comes to timing. Because if you remember the old BIS data on awareness, 1 or 2 minutes of too shallow anesthesia, especially if you are under a nociceptive stimulus, were sufficient to increase the risk of awareness. And if you look at the overdosing, the triple low data consistently tells you that 15 minutes or more of triple low state is associated with an increased risk of death. So the resolution of inadequate anesthesia is quite short, 2 minutes for awareness and 15 minutes of cumulative overdosage for increased risk of death. So now I gave a patient 2 milligrams of propofol. He received 15 micrograms of sufentanil or 150 micrograms of fentanyl. 2 minutes after the bolus is given in the same time. MAP goes up, and so do the NOL values. So the mechanism, one is insufficient opioid. Who votes for insufficient opioid? Nobody? Second mechanism, enough opioid but not enough time. This is what you say. Well, this is the time to peak effect for sufentanil, and fentanyl is about 5 minutes, shorter for remifentanil, and this is what happened with this patient. Simulation, the propofol effect site concentration peak 2 minutes, it was okay, but look at the peak effect for sufentanil 5 minutes. So the answer in this case is I was too early, okay? Now this is probably the less well understood part. I'm sorry if you feel like being aggressed by me repeating those issues. This is the isobologram of hypnotic opioid concentration when you apply a nociceptive stimulus. So that tells you that 1 + 1 is much more than 2. And then you can either work with very high concentration of a hypnotic and zero opioid, or you can then increase the concentration of the opioid up to a certain level, which is about 80% sparing of the hypnotic requirements. And then there's a point of maximum interaction. Do you know what for sufentanil this point of maximum interaction would be? Well, it would be about those 15 micrograms per ml. This is very, very low concentration of opioids, which already take you to this point of optimum interaction. This is the bottom line. And the second message is that you cannot look at the effect of an opioid without taking into consideration the concentration of the hypnotic. The two are indistinguishable because for a given patient you can use an infinite combination of a hypnotic and an opioid. And this is something which is very important. And interestingly, what happens for a nociceptive stimulation is different upon loss of consciousness and is very different upon emergence. So this is something which is widely addressed in the literature, hysteresis between induction and emergence. They are not similar. So whatever information you get upon induction will not be able to be applied upon emergent and vice versa, okay? So once you have managed pharmacology, then you can go for titration algorithm. And this is where we get for the titration algorithm, okay? So one can, if you ask questions, we can, both Professor Sessler and myself, based on the two presentations, I know what then Professor Schrag will show you, but we can bring you arguments that things, based on the literature, that things which brought us to build up this algorithm actually exist. So the clinical reasoning for a given patient is going to be on 3 parameters. MAP, mandatory, no problem. Heart rate between brackets. Then the processed EEG. Okay, now you can use the whole, you can improve your reasoning in going from MAP and heart rate to one additional parameter, NOL. Or you can use MAP and EEG. Ideally, I think you could use all 3 of them. So MAP looks fine. EEG, if used, looks fine. And then you have an increase in NOL. Okay? So you need to look what the stimulus is. Is it incision? Is it intubation? Is it something else? You need to define what the stimulus looks like. Okay? Then you need to consider increasing opioids. But if you did not take into consideration timing, you may be wrong. So in what I showed you, if you say, okay, my NOL went up 2 minutes after sufentanil, and because the NOL went up, I was told that I should increase the opioid dose or concentration, but the problem is you didn't wait enough. Okay? You didn't wait enough. So once again, TCI helps you, and if you don't have the TCI device, thinking TCI is also going to be helpful. Now, if the pressure is up, okay, and the NOL is lower than 25, that may imply that your increase in arterial blood pressure doesn't come from an insufficient level of anti-nociception, insufficient opioid. And in this case, you can consider giving a vasodilator. Okay? And then if your NOL is very, very low, well, you also need to look whether is there no stimulation. That can be the case. And then you can look at reducing the opioid concentration. So in the absence of a nociceptive stimulus, if you have too much opioid, how is going to be the blood pressure? Low. Okay. Now, let me remind you that if you have too much sufentanil or fentanyl in the patient already, the time to elimination is going to be long. If it's remifentanil, it is going to be short. So the treatment of the cause would be to decrease the opioid concentration, okay, if your blood pressure is low. But you are still allowed to do something like symptomatic treatment, because if you have the opioid which is not eliminating fast, you know what the mechanism is, but you cannot correct it. So you have to do a symptomatic treatment and still give a vasoconstrictor. This is exactly the clinical reasoning that we need, okay? Now, opioids with low MAP and low heart rate. Once again, you can find the easiest solution, which is convergence between low MAP and too much opioid. The NOL is going to tell you, because it will take into consideration the level of nociceptive stimulation. So the same comment as previously. If the NOL is okay, then you should correct the hemodynamic abnormality. So we're not telling you how to do it, you know how to do it. And if the NOL is high, you can have, in this case, dissociation between MAP, which is confounded by something else, and you can still have some increased level of nociception and not enough opioids around. That does exist. So what will happen if you give additional opioid? Well, difficult to say, but clearly you have an information that there's dissociation between low MAP and high level of nociceptive stimulation. So this takes you back to all the possible combinations among the three parameters. Now, confirming the original block effectiveness. You remember that there was a meta-analysis in 2014 coming from Joan Guay in Canada, looking at the effects of regional anesthesia. And you remember what that meta-analysis said, that is, if you're doing regional anesthesia alone, you could have measurable improved outcome for the patient. But if you are doing general anesthesia with some kind of local regional anesthesia, that exposes you to an increased risk of arterial hypotension. So that negated the beneficial effect. There was nearly 10,000 patients. Well, how comes? It comes because I showed you that if you block the arrival of the nociceptive stimuli, then you will shift the whole balance between drugs and the effect on general anesthesia. So under blocking of the nociceptive input, the MAP is still a variable. The processed EEG, if you use it, still can be. And then if the NOL is very low, then probably your regional block is effective. And in this case, you can lower your hypnotics, and you can lower probably the opioids quite dramatically. And if you don't do it, this is probably the situation where you expose the patient to too deep anesthesia and also expose the patient to low mean arterial pressure. If the NOL is high, that means somehow that your regional block is not effective, or you didn't wait enough, depending on what kind of drug you used, okay? And once again, patient under general anesthesia, the NOL would provide you with information, is my regional block effective or not? So, sudden increase in NOL upon nociceptive stimulus, it can, and in my experience, it is more sensitive than the hemodynamics. I don't know what Professor Sessler's impression is, but my impression is that it is more sensitive. And in this case, you stop the nociceptive stimulation temporarily, and then we can discuss for hours if you give more opioid or if you give more hypnotic, because even with NOL, this curve of the interaction between hypnotics and opioids is still valid. And then do not forget that the time to peak effect, if you're using fentanyl or sulfentanyl, is about 5 minutes. Okay? So if you will not overdose the opioid, you will need to wait a little bit. This is why you temporarily stop the nociceptive stimulus. If there's no problem in increasing the dose or the concentration of opioids, such as with remifentanil, then this is not an issue. And of course, there may be a risk of explicit awareness, especially if you have what we call a cortical arousal, and BIS goes up. And do remember that the data we have now is that 1 or 2 minutes of cortical arousal simultaneous with the nociceptive stimulation are sufficient to increase the risk of explicit awareness dramatically. So, if you believe that opioid-free anesthesia is going to be part of the landscape, I don't know, possible. Well, then we basically take away all the clinical reasoning on hypnotic opioid interactions, which we now understand we can describe, and go for a cocktail that we do not understand in terms of interactions. And in this case, you don't know where you are, especially if you're using dexmedetomidine, who will actually obliterate eventually the heart rate response. And in this case, I would say that with opioid-free anesthesia, well, the requirement for monitoring is even more important than with the classical opioid hypnotic. So if you have a NOL, which after the cocktail of opioid-free anesthesia is consistently low, and if you also have eventually you're not opioid-free but opioid-sparing, consider looking again at this issue of dose or concentration of the opioid. And then if the NOL value is higher than 25, then if you were for opioid-free, then you should go for opioid-sparing, okay? So I think there's credible evidence that inadequate anesthesia is associated with poor post-op outcome. And remember, when this whole issue came to the attention of the clinicians in the early 90s, it was about the insufficiently deep anesthesia and awareness. And then we realized, after getting tracing and thousands of patients, that the main problem, hidden problem, is too deep anesthesia, okay? And well, I have a few slides if someone asks, but if you look at the mechanism of too deep anesthesia, which should be actually a motivation for you and for us in general to look differently of anesthesia, because before this data between the association between too deep anesthesia and poor outcome came, what we were told is that the presentation we're doing were nice for academics, but you as a frontline anesthesiologist could do without it, and you do it every day, okay? The problem is that with thousands and thousands of patients in the databases, now the association is not causality, is there repeatedly. So we should require from ourselves a change in the way we look at the anesthesia. So in the hypothesis, well, you have immunodepression, you have neurotoxicity, and there's something which is stated, well, you should have some hemodynamic alteration, and this credible, unfortunately, old data showing that the anesthetics, most of them, hypnotics and opioids, increased the critical oxygen delivery for which the cells become hypoxic by altering the flow-pressure relationship. That is credible, honestly credible data. So the algorithms for titration are for the moment not explicit. Okay? So the first algorithms were published was Gourmand's algorithm. We published an algorithm in anesthesiology in 2003, taking into consideration in cardiac surgery patients the math. And I think that we need, for the sake of facilitating your clinical reasoning, to make proposals for algorithm that will include all parameters on which you can take decisions. But that is fundamentally based on some knowledge of pharmacology. And if that knowledge of pharmacology is not correct, well, I think that the whole system is going to be unstable. And I think that in the absence of algorithm, validated because they have not been properly validated, the correction of inadequate anesthesia may not improve outcome for many reasons. Thank you for your attention.